Hi, everybody. I know it's 2:31. I also know a few folks aren't able to join us today. Both Renee and Randy let us know they have conflicts. But even so, I think we're expecting a few more. So I'm just going to give it another minute to 2 minutes and see if a few more advisory council members join, and then we will get started. I'm going to take an opportunity just to double check. Rudy, want to make sure you can hear us and that you can come off mute and things if you want to do a little test run.
Yep, I can hear you guys okay. Can you hear me?
Perfect. Great. Thank you. Okay, I think we've had a couple more people join us. Definitely maybe a little bit of a thinner group than usual, probably to be expected coming back from a holiday weekend and at a time that I know is really busy between back to school and kind of wrapping up this summer. But thank you all for being with us and joining us today. I'm excited to jump in and finally be able to discuss the dashboards that I know took a little bit longer than expected to bring to you all, as well as a couple other topics on today's agenda. So I will jump right in. For some reason, my laptop is being really slow, so bear with me. Here we go. Briefly, an item on the agenda that I'll just cover on this slide is I just wanted to share an update on timing for the annual public hearing that we're required by statute to hold each year. We've landed on Tuesday, September 29th at 1 p.m. for that meeting. And we're going to use a very similar structure, pretty identical to what we did last year. So once again, we'll share a presentation with some updates, including new data work we've done and some of the other kind of topics that we've discussed in this meeting, and then turn it over for public comment. We put together a couple submission forms like we did last year. So there's one for anyone who's looking to testify. Once again, we'll support doing that either virtually or in person, as well as an option to submit written comments. And we're going to do what we have done in the past and take written comments for a while after the presentation so that folks can respond to what we share if they'd like. And given timeline, we were actually able to give a little bit more time. So I think it's about 2 weeks that folks have to provide written comments. So I'm going to be sending out a note, I think this afternoon, to the interested parties list to let them know about this, but just wanted to put an extra flag on it for members of the advisory council. And as usual, appreciate your help sharing the word about that among anyone who you think might want to attend, either to listen or to listen and to provide testimony. Any questions on that? It's pretty straightforward this year. So moving on, the first agenda item that we had up was a presentation from Rudy Rudinsky, who is a student at the University of Southern Maine Muskie School, getting their degree in public health. or their master's in public health. And I think those of you who joined the last meeting got a chance to meet Rudy. And so we just wanted to give an opportunity for them to come back and share a little bit of their work with you. In working together, we had identified looking at access to behavioral health care as kind of a project topic for them. We know that that's an issue that's come up a lot in these conversations and that is timely and relevant for us as a state, and something we kind of collectively hadn't had a chance to do was get a sense of what's happening in other states and a little bit of a landscape review. So Rudy has done some research on that, and I'm going to hand it off to them to go through a few slides and just kind of summarize their research to date. So over to you, Rudy, and I will move along to the first slide.
Great. Yeah. Thank you, Meg. As she said, I had the opportunity this summer to work with the Office of Affordable Healthcare to assess options to improve behavioral healthcare access in Maine. So we'll look through three topics: prevalence and access to treatment in Maine, other state initiatives, as well as some Maine initiatives to improve behavioral healthcare access. So to start, to assess behavioral healthcare needs in Maine, we looked at survey results, including results from the 2025 Community Health Needs Assessment that found that mental health is the #1 social concern for Maine residents. Results also showed that 73% of residents reported a negative impact of behavioral healthcare needs on themselves or a community member. And finally, that 39% of these respondents reported lack of access to behavioral healthcare treatment and services. These findings were also supportive by results from the Health Resources and Services Administration health professional shortage areas. HPSAs, as they're called, identify a geographic area, population type like low income or homeless population, or a facility experiencing a shortage in healthcare professionals. HPSAs are designated as primary care, dental care, or mental health care professionals. And in Maine, 15 of the 16 counties have mental health professional shortage areas, indicating that almost every county has a shortage of mental health care professionals based on the geographic location, a specific population type, or at a facility level. Next slide, please.
And I can jump in because I'm realizing, Rudy, I failed to share one piece of background. When we started working on this project with Rudy, we found that the scope was very wide and needed to narrow a little bit. So we did ask Rudy to kind of focus their efforts on actions in the commercial healthcare space, knowing that other colleagues have spent more time and focus on Medicaid, for example. We have limited impact in the Medicare space. So just a quick note there, if you see pieces missing from those other areas, it's because we kind of tried to focus in to help with making the scope a little bit more reasonable. Sorry about that, Rudy. Back over to you.
No problem. Thank you for that piece of context. It's definitely important. So identified several initiatives across various states to examine how they're handling similar behavioral healthcare needs. Spending benchmarks were something that was recurring. So benchmarks have been used as a helpful tool to incentivize spending on certain types of care. In Rhode Island, Oregon, and Connecticut, they've created benchmarks for primary care spending as a portion of total healthcare expenditures. And this allowed these states to work with insurers to reach primary healthcare goals, spending goals, and focus efforts on making primary care more accessible for their members. Now, California is the first state that we've found so far to use this similar ideology to create behavioral healthcare spending benchmarks. And they're currently in the process of developing their spending methodology and their data collection process. And they're planning to implement this sometime in 2026. Reference-based price floors are another type of initiative started in Washington of this year. They passed a law earlier in 2025 that uses reference-based pricing of 150% of Medicare rates to create a lower limit for behavioral health care and primary care service prices. This applies only to their PEB and SEB health plans and will be implemented starting in 2027, hopefully with the outcome to incentivize providers to work with these health plans to provide care to their PEB and SEB members. For addressing gaps in behavioral healthcare coverage, Oregon is one of the few states to directly address this by passing a law in 2023 that stated that case management and care coordination have to be covered under fully insured group and individual health plans as a part of overall behavioral healthcare treatment. Additionally, Oregon has provided incentives to help providers, behavioral healthcare providers join the workforce. Between 2021 and 2023, they provided $2 million to behavioral healthcare organizations to fund sign-on bonuses, retention bonuses, and housing stipends to their providers. Qualifying organizations could be awarded up to $120,000 over the course of 2 years. So from there, we wanted to look more at the initiatives that are taking place here in Maine. So to start, Maine is very familiar with behavioral healthcare spending reporting with the annual behavioral healthcare spending report put together by MHDO that looks at how much Maine is spending on behavioral healthcare as a proportion of total healthcare expenditures. In the commercial market in 2023, this amounted to 8.3% of total spending on behavioral healthcare, with an increase from 7.3% in 2021. To address gaps in behavioral healthcare coverage, like case management, the Office of Maine Care Services has been collaborating with state partners to support certified community behavioral healthcare clinics, CCBHCs, to implement and expand services in Maine. These clinics combine case management, behavioral healthcare, and primary care services, all within one practice to kind of help generate more of a wraparound approach to behavioral healthcare. And finally, Maine is working on two important workforce initiatives that are supporting behavioral health care providers joining the workforce and maintaining and staying in the workforce, including Building Maine, the Building Maine Network, which was launched by Maine DHHS using funding from the CDC. This helps streamline clinical placements for trainees and preceptors into rural communities where it's needed the most. And finally, the student loan repayment tax credit, which provides $2,500 annually and up to $25,000 per lifetime for Maine taxpayers with an associate's, bachelor's, or graduate level degree. And through these initiatives, we're hoping to highlight some of the work that Maine is putting together to reduce barriers in behavioral health care, as well as highlighting some of the other initiatives in other states in hopes that we can use future initiatives like that here in Maine. So I'd be happy to take any questions on some of the things that we found when we were looking at the research. Otherwise, I'll pass it back to you, Meg. I know you guys have a really full agenda.
Thank you, Rudy. Just briefly, happy to let folks pose any questions to Rudy, but there's one final part of their project, which is giving us some recommendations on how to assess these policies in the state of Maine. You know, we felt like it was a tall order and probably a step too far to say recommendations given all the context and things that need to be considered. But they were just wrapping up that project, so we weren't quite ready to share that. But thinking about things like, are there changes in the methodology for the behavioral health care reporting, or thinking about getting a handle on where commercial rates are for behavioral health services in comparison to other types of coverage, types of care, or comparison to other states. So kind of a starting point, but giving us a sense of kind of what are some next steps that we could think about in terms of identifying promising initiatives here.
Yeah,
Yeah,
thank
you
you,
want to
Meg.
go first, Katie, and then I think I see Mallory's hand up, but let's start with you,
Katie. I love the idea of looking at both our rates compared to other states, but also, and compared to other services, but also coverage. Are we covering the same types of services? Because the case management really, for Oregon, caught my eye.
Yeah.
And I'm just curious. I mean, there are so much that Medicaid covers that commercial doesn't, and it would be interesting to see if other states have expanded to cover more of the Medicaid types of services.
Yep, I agree. And that's something to call out in terms of thinking about the CCBHC model.
Right.
You know, that's one example in terms of Medicaid, but the idea of could there be buy-in for commercial payers to kind of align with that model if it demonstrates success? I think that's really interesting. And we'll just note in conversations about this, I think Medicare just recently started paying for some case management, case coordination codes that historically they hadn't. So it does feel like there's, you know, some movement at that high level towards thinking about the value of those kind of services in traditional insurance and for broader populations outside of the Medicaid program. It's always a tricky one, as we know. Insurance regulation and limitations on state reach are a challenge, but that's something I'd love to talk more about in future conversations. Sorry, Mallory, to take a minute to get to you, but please, love to hear your question or your thoughts.
No worries. So I think this is great. What Oregon is doing is some great work. They're doing expanding access and affordability tremendously for behavioral health care. So I think looking, further into some of these comparisons would be good. The case management, as you say, is a critical piece when you talk about providing access to behavioral health services and coordinating those services. Many people who are seeking those services need the addition of case management to actually and function. services. And when we're looking at things like this, though, and existing Maine initiatives, I think more than just the surface view is needed, because the CCBHC model is something that we've been trying to get into the state of Maine for a number of years and have successfully finally brought it to the state of Maine. But and it is a major step in the direction of making access and affordability for behavioral health services to people much greater. And I think the idea of private insurers participating in that model is a great next step. But how are we really actually supporting it here in Maine? I think deserves a deeper dive, because it has been a struggle, and many of the agencies that took the leap into providing it are struggling to maintain it because the policies of the state that keep backtracking on the funding of it. So I think even though the investment there is, again, it's the return on investment. The investment return is tremendous, but it's got to be invested. And I think that, when we get a presentation like this, we really need to see a little bit deeper, like how successfully has it panned out in Maine? How much access is there, and have people already retreated from the model because of existing policies that are counterproductive? So I do think that we need to look at that a little bit deeper. And the workforce initiative, the student loan repayment tax credit, is that are you talking about the healthcare access one? Is that what that's referring to, specifically healthcare? Or I mean, is this isn't something that just happened? This is the one that's been around, correct?
Yes.
Okay,
Yeah,
so
this is, sorry, Mallory, this is the general one. Our understanding is the pilot program that was health provider focused had expired because it was funded with one-time federal funds. So
Yeah.
we had reported on that when we were putting together these slides. I said, maybe let's focus on the programs that are, currently in place. Although they had noted
Okay.
that one. So on the radar, and sorry, don't mean to interrupt you. I did want to clarify that. We looked at both, but this is
good.
the one.
That was sort of the question I had. And then again, what is the competition to try to get that, and how many behavioral health folks, how many people in behavioral health have actually received it? I don't know how impactful it has been. So I just wanted to, not to rain on any, new initiative excitement, but there's more to the story than just that it exists. It's got to actually function properly to really make any improvements. So just want to throw that out on the table.
Yeah, I can actually speak to the pilot program that we were talking about, that Meg had referenced. So in the the most recent round, that closed earlier in 2025, 11 behavioral healthcare professionals were awarded repayment for that initial pilot program. And the first round, from the sources that I could find, 18 recipients had been awarded repayment, but it didn't specify how many of those went directly to behavioral healthcare professionals. Oh,
I
sorry,
think you
Mallory,
were
I
on
believe you're
mute.
muted. Yeah.
As I said, I think there might have been one out of those healthcare professionals, but I may be slightly off on that.
Yeah, I think it's a good point. We've talked a bit about initiatives like that. Obviously, it's always a challenge when it comes to just where do you find funding for programs like that, and also a little bit internally about talking about how do you ensure that a program like that is achieving the goals in terms of actually, developing and seeing providers through and making sure that they're, working in areas that are most in need, kind of across the whole spectrum of healthcare professionals and programs that incentivize service and means. So I think there are some interesting pieces in the research that Rudy did in Oregon around sort of public-private partnerships and figuring out if there's ways to structure programs that could be more sustainable, that aren't kind of one time or only government funding, and also that kind of make sure there's like a continuum of support to try to make sure that they're as impactful as possible. But don't totally hear you as well. I know we talked with some of the MaineCare team quite a while ago about the CCBHD model, and that was early stages. We haven't been as close to kind of rate development or some of the other changes and updates there. So completely hear you, Mallory. I think this was just a helpful starting point for us, again, in getting a lay of the land of, the question we really posed to Rudy when they first started was, what else is out there in states? Is there a great idea that we're missing? And I think there's some pieces to learn from, although probably not anything brand new that's not at all on the radar. And then just getting a sense of what's happening here and being able to summarize that. But understand this is only the start of the conversation and by no means kind of an answer or a reassurance that we're fixing the problem.
One piece I would, one little program I would throw out there that'd be good to get a little more information on is and I'm not sure exactly where it stands now, but I believe it was Oregon as well, or might have been Washington State, thinking Oregon. But they, how we have teaching hospitals as a way of bringing people into the field and giving a little extra to hospitals to do their work and to bring in and train people. They have an initiative for agencies like behavioral health agencies to become teaching agencies with an enhanced rate to do a similar situation. And I think that that's a model everybody should be looking at as well. So just to throw that out.
If I could build on that, Mallory, one of the things that we're finding with new grads, and particularly in our new environment, that our new grads, whether they be nurses or social workers or any type of clinician, are really not ready to treat patients. And so we are developing residency programs for like our nurse practitioners who are new grads, very successfully so, and a social worker residency program. But that's a really good point. We're doing it internally, but it would be great to have support and to do that across different agencies, because it makes a difference. And then people are supported, they don't get burned out as fast.
Not thrown in immediately.
Throwing them in with especially, tough psychiatric issues that can be.
Great. Yeah, we'll take a look at that program and see if we can turn up some detail. And if not, might follow up with you, Mallory, for help in the right direction. But I'd be interested to understand that a little bit better and how they funded it. Perfect. Any other questions for Rudy? Wonderful. Well, big thank you again, Rudy. It's been great having them as part of the team. Rudy's background is more quantitative in the health space. And so we've also been able to learn from them a little bit in their expertise, but it's also been fun to kind of share the world of policy and some of the unique challenges, but interesting components too, I think, to kind of researching and understanding the landscape and thinking about how it can apply here. So much appreciated, Rudy, and look forward to keeping in touch and seeing what you do next.
Yes, and thank you all for your help and all your feedback to Meg and Kaylee and to you, Katie, and to you, Meg. Looking forward to working with you guys in the future. Thanks again.
Well, thank you. So then moving along, the next section of the agenda is focusing on the dashboards that we shared around last week for folks to start taking a look at. So I'm going to hand it over to Katie for these slides and then to do a demo for us.
Absolutely. Thank you, Meg. So as you may remember, just a quick refresher, we have this bold, larger analysis plan. And today we're just presenting an update on a smaller portion of the plan, but a good amount of work, the hospital level or facility level payment and utilization dashboards, which are part of a larger dashboard initiative. And to provide a short overview, as you may remember, we've been working with the Maine Health Data Organization and their all-payer claims database to create hospital-level dashboards to measure payments and utilization across hospitals in Maine, with a purpose really to identify and describe variation in payments and utilization across these facilities. The metrics that we report are total payments and payments per unit for 3 categories of services that would be inpatient, outpatient, and professional hospital services, as well as total utilization. And then also being able to report on select service level total payments and utilization with the aim to try to control for the complexity of certain services. So to be able to look specifically at a DRG or a CPT level. And we heard from you all last time that cost sharing payments might not be as helpful to look at a whole facility level. So we ended actually suppressing those for these dashboards and really just focusing on total payments, payments per unit, and utilization. And just as a refresher of the timeline for these projects, so the original timeline has been adjusted, as is the case sometimes with more complex data projects and projects in general. So as you can see here, the green diamond indicates we are coming up on project completion with the review of the dashboards from you all here in early to mid-September. We're hoping to show you today a demo and a function of the tool and then present at our public hearing some of the data as well. And then, as you may remember, there's what we call phase 4, which is an iteration of these dashboards that goes further to look at the non-hospital provider type. And so that would be looking at things like ambulatory surgical centers or federally qualified health centers and looking at some payments and utilization there as well. We're expected to have completion of those in late October. All right, so for today, we will be overviewing the hospital level dashboards. And as I said, this really is just a demonstration of the functionality, and happy to take some time to show you, what the dashboards really can do, but not here to describe any takeaways at this point. And one more slide.
Oh, yes.
Yes, just wanted to highlight. So today, for ease, we'll be looking at payment and utilization across the main peer group B hospitals. We talk a lot about, our larger hospitals in the state, and we thought that'd be a good opportunity to look at some of the smaller general acute care hospitals. The Maine Hospital Association creates these peer groups, and so here's peer group B. You can see based on the locations, they are, spread out across our state, but are lumped together based on the services they provide, as well as the relative sizes of these facilities. And I'll just note, for the purposes of our hospital dashboards, we refer to Maine Health, Maine Medical Center, Biddeford as Southern Maine Medical Center because, okay, yeah. The dates of the dashboard.
Went back and forth. We were like, well.
I just want to know.
I generally refer to it that way too.
Okay, great. For the purposes of the dashboard, the data happened before the merger, and so it is referred to as Southern Maine.
Okay.
Thank you. All right. So
I think before we move on from that one, remind me, I think there might be a similar dynamic with one of the critical access hospitals. Am I right about that in classification?
yes,
Yeah.
Maine Health or Franklin
Franklin.
Memorial Hospital is transitioning to a critical access hospital.
It transitioned in 24.
But just
Thank
a
you.
flag, this is something that caught us up a minute, and we debated how to classify, but we thought for the time being, again, we'd use sort of classifications based on what the data represents, and as there's a transition, we can change that in future iterations. I just thought I would flag that in case anyone else comes across it and says, wait a minute.
That's a really good point.
Okay,
So I will move to share and go.
bear with us as we undertake a transition here.
Hopefully seamless. Okay, great. I'm just going to move this. It might be kind of small in person, but can everyone see this okay? I apologize, Katie. This is probably small.
If you're talking to me, not other Katie, then I'm
Yes.
good. I'm fine. Thank
And
you.
she is the other Kate.
I am
so
the
it's
other
one
Kate.
time
Oh,
when you
yeah,
come
that's
to us.
We might both have trouble
Good
seeing
point.
this. All right, so just to orient everyone to the dashboards here, to the left, there's a health system payments and utilization tab that we won't be covering today just for time, but have all the same information as the hospital payments and hospital utilization tab, just at the health system level. The first tab here you can see is hospitals, and it shows our 36 hospitals here. And I'll go through and click our peer group B hospitals quickly. Here we go. You can show up to 9 hospitals at a time. As we were told, looking at more than 9 at a time might get a little bit clunky. All right, and then we'll start with looking at total payments. For the purposes of today, you can also pull up 7 different payers. We'll be focusing on commercial today, as we often talk about the commercial market here, but you could also see MaineCare, Medicare, and dual eligible payers, as well as commercial and Medicare. And all of the way to the right, you can see we have 3 service categories: our inpatient, outpatient, and professional service categories.
And Medicare Advantages and Medicare.
Yes, so for these dashboards, you can actually pull out original Medicare or traditional Medicare and Medicare Advantage separately, or if you just choose the Medicare, it wraps them both together. Of course. On the left-hand side are data over the span of 2017 to 2023, and on the right-hand side, you'll see the year-over-year percent change. What I'll note about year over year, especially looking at hospitals that have smaller utilization, is you might see some pretty dramatic swings in utilization or payments. The year over year percent change is affected by the number of services provided. So a small hospital may have a big change from one year to another, and that could just be them increasing their services by a much smaller amount than a large hospital that might have, hundreds or thousands of increase in utilization of services, but it looks like a much smaller relative change. So to start looking on the left-hand side from 2017 to 2023 across our main peer group B hospitals, for inpatient services, total commercial payments have been relatively stable. You'll see here, this is Northern Light Mercy, has this downward trend for inpatient services to 2021. And you see a small increase here in Southern Maine Healthcare in 2021 as well. But and then across other hospitals, you see a more steady total payments for inpatient services. And then you can click and see how that might change looking at outpatient. So outpatient, we see a different story, especially with Mercy and Southern Maine Healthcare having a higher total payment here, with our other main peer group hospitals staying slight increases here and some steadier trends across this time. We next can look at utilization, and I'll just quickly specify our hospitals again. Apologies here.
It's probably a good moment to say, right, with the demo, that selections don't carry over, that they need to be reselected when you look on a new tab.
Yes.
This was definitely one of the functional challenges in working on this that you'll see with both the hospitals and the trends by service. When we have just like a long list and multiple variables, it gets a little tricky. So worked on that. It's a little bit of a clunkier interface, but there are just some limitations to what Tableau can do. So,
or it's a great opportunity to start memorizing your hospital peer groups. You could think of it either way. So here, looking at utilization, so this is total utilization at each of these facilities, and I've highlighted here commercial inpatient. What we can see here is across all of these facilities, we see a trend of decline in inpatient utilization, especially here, this blue triangle is St. Mary's. Here you can see a more dramatic decrease from 2021 to 2023. And then looking at outpatient services, we can see for a good chunk of peer group hospitals in the middle here, it's pretty steady, with some hospitals that have that higher utilization seeing, especially Southern Maine Healthcare, maybe a decrease in outpatient services. And I think this is Mid-Coast here in this blue square, showing more of a steady relative from 2017 to 2023 trend in utilization. What I will note, this is something that we talked on the right-hand side with our colleagues from other states. This big increase in outpatient utilization in 2021 could be due to a variety of things. Something that someone highlighted, that vaccinations is included in our outpatient services. And so that if you look through these graphs and see some of these, bigger swings across all facilities, impacts of the COVID-19 pandemic and different things like, large vaccination efforts will show in these dashboards. And then finally, I'll just look back. Our other unit is payments per unit here. And so here in this, as long as you don't refresh, your hospital should stay the same. So I won't have to re-choose those. But for inpatient services here, for payments per unit, what we can see is that there is variation in payments per unit across these peer group B hospitals. The trend for like Southern Maine has been increasing steadily, where our other hospitals have had different types of fluctuations. But there is a spread across our peer group B hospitals here for inpatient services. And then for outpatient services, we can see, again, increasing, I would say, for a trend for many of these hospitals, with some more steady than others. And the thing I'd like to highlight here is, as we talked about earlier, the payments per unit, when looked at large categories, doesn't take into account the complexity of services provided at each of these facilities. However, this is where we're able to look at our trends by services tab to get a better sense of, if we want to compare one service to another, we can actually pick a specific CPT code or DRG code and get a sense of, at a service level that is controlled for as best we can, the complexity, what is the price and utilization. So here on this trends by services tab, I'll just note you can fluctuate between a graph or a table. And choose here, I'm choosing payments per unit for commercial, and I'll choose our outpatient services here. And then if I go down and look at, for example, we can look at emergency department, and we'll just choose emergency department for a low-level medical decision. And then I apologize, let me go back through. Glad I brought my mouse today. And get our peer group B hospital. What we can see here is, looking at the same service being provided, we see a spread of average prices across the years. So what we can see here for this CPT code, Maine Health Penn Bay Hospital on average for 2023 is around $404 for this service. And our highest, which is Mercy, is around $1,055. And this is in the commercial market on average for this CPT code. What I think is also helpful with the Trends by Services tab is it gives you a sense of how, when complexity increases, what does payments per unit increase? So for example, if we wanted to look at an emergency department visit for a moderate level medical decision, you can see how our y-axis here and the price has increased. And so our hospital breakout has remained relatively the same, with Mercy still at the top and Penn Bay close to the bottom here, but that average value has increased, which I think, probably makes sense to everyone. As the complexity increases, payments per unit can as well. The last thing, I'll show one more example of what you can do here. I will say it's a little clunky in the services tab. So usually you have to work bottom to top to clear everything out. But if we were to look at something like a CT scan, for example, we'll do CT scan of chest. We'll just do without contrast, for example. You can see a similar price variation, but this time our peer group B hospitals have a different ranking, I would say, for price. So here we see Penn Bay now has moved to the top of the payments per unit for the CPT code at just under $1,500 for this service. And our Mercy, which was at the top previously, is now more in the middle of the pack for this code. So I think this is an opportunity here where we can look at, for a given complexity, for a given service, what do our payments per unit look like? And you're also able to toggle, look at total payments or utilization across these as well. Yes,
Done?
done,
Okay.
all set, but happy to answer questions. Again, this was just an opportunity to present the functionality of this tool and to give people a little sense of what this looks like, but really are looking forward to your review and any thoughts you may have, highlight any trends that you think are interesting or curious, and we'd be happy to look into those.
And I can add, just in terms of, purpose for these are definitely more complex dashboards. And I feel like whenever we get more granular with data, it also becomes more difficult to use and digest. And that's a challenge, and one that I think we're trying to think through. But our goal here is, obviously last fall we released the high level spending and utilization dashboards, but getting a sense of, how consistent is the trend across individual providers, and payer groups, is informative in terms of understanding, is everyone roughly on a trajectory that sort of looks similar to that, or are there outliers either at the facility level or at the service level that we can identify. So that's the work we want to spend more time with on these dashboards, but it feels like an important next step, and then gradually to expand that out, as we said, we intend to do for October, to look more broadly than hospitals, but to get a better sense of, what are the underlying trends that build up and contribute to what we see at a more kind of statewide level. Just briefly, a couple notes on these two that I'll ask Katie to correct me if I'm wrong about. I just want to highlight the MaineCare payments piece that was a feature of the last dashboards. A limitation is the issue around collection by MHDO of information on payments from MaineCare to critical access hospitals, that because they're not on the same sort of fee-for-service payment schedule, that was a data gap that is gradually sort of being filled prospectively, but is an issue for us with historic data. I think a nice thing about this is because it is not an aggregate, we can look at hospitals that aren't impacted by that, but just a flag there. I just sort of wanted to say out loud in case people had forgotten that that's a limitation in terms of looking at MaineCare payments in these dashboards, as well as a little bit more impact for them from non-fee-for-service payments. And then the other, caveat that, again, I think sophisticated users will know, but we want to be clear about too, is I think some variation in kind of billing practices and the structures of given hospitals and health systems can have an impact here. So one thing I'd call out that stood out to us when we were doing a review was we saw that Maine General Health had pretty high outpatient utilization. And it really stood out to us because we were thinking, just knowing relative size, we'd expect Maine Medical Center probably to be at the top there. And so the MHDO team had taken a look at data, and it looks like maybe it might be how laboratory services are kind of included in the count of outpatient services. So there are some pieces like that, and like how hospitals, may bill, one hospital or health system may bill more on professional service claims, while another might do more institutional billing, and that can create a little bit of difficulty in directly comparing. So it is helpful, I think, to look at sort of each of the payment categories and get a sense for variation there. So a few caveats, as we always have every time we present data, but I thought I'd make those. So I'll stop talking and pause and see if anyone had, reflections or feedback. I don't know how much time folks had to maybe tap through these. As always, we always appreciate extra eyes, especially if there's something that jumps out as a question or concern. So would love any feedback.
I have a couple of questions. I haven't had a chance to personally spend time on this, but I did send it to our team, and they had two very technical questions. And you may have started to answer it related to CPT codes of DRGs. I think they were specific to making sure particularly with Maine Medical Center and Eastern Maine, our tertiary care hospitals, that they're for NICU, those would be the only NICU, but NICU and the critical care services are appropriately risk adjusted. And I'm not sure they feel like the coding is going to risk adjust. So that's just something to think about.
Mm-hmm.
And it may be that we want to look at risk adjustment outside of the coding anyway, but I don't know enough. I don't have enough background to be able to speak more eloquently to that at the moment. But the other question I have is really more broadly, how you anticipate using this data going forward. I mean, what do you see? How do you see the state using this data, or users? Who would use it and how?
Yeah, I think, like I said, it's really about getting at that question about variation from trend maybe, and understanding if there are outliers from what we've seen in the data, looking at overall spending, utilization, and per unit payments. And that's where, I think we want to spend more time to understand if there are trends, because I think there's curiosity and interest, right, around, are there services where most providers are pretty close in terms of their payment rates. Are there others where there's a much broader variation in the average payments for a given service, and sort of understanding what is the distribution of that and what is the magnitude of it, which these dashboards allow us to do because they consider both the per unit price and utilization. We know it's an imperfect way of doing it because, again, there's just limitations to this data. One of those is service intensity. There's just no way when all we're working with is claims data for us to make adjustments, I think, in an accurate way, or it's very challenging, I guess. We've looked into that and so felt like as close as we could get is getting down to the code level, and would welcome if there are particular codes where folks who are in the weeds on this feel like there is a wide variation in service intensity. We're really happy to take that input. But so it's an imperfect way to do that, but I do think it helps us get a sense. And I think it's really interesting to see for someone that, across all cases, it's not necessarily that the same hospital is charging more, right, for all services, that there can be services where one hospital is at the top of the list and they're at the bottom in another. I think that that's information that just isn't necessarily visible or available, especially not in an aggregate way and not kind of showing trend over time right now, to help people understand, again, like what are the different elements that are making up the overall trend that we're reporting.
And that's actually aligned with my thought, which is really for policymaking purposes, it's really about the total cost. It's the total spend for it, the variation in total spend for an episode of care or for, I mean, I worry when we get into the individual services, because to your point, on the outpatient, we might have a CT scan that's up here with one hospital, but they charge a lot less for the professional fee associated with the visit. So they're balancing it all out in this insane world of healthcare financing in which we live. So I just worry that that this can be sort of picked apart without looking at the whole picture. And the whole picture seems that seems like the thing we should be focused on if we're looking at affordability more broadly. But that's just an aside. So I will stop there.
No, I think that's a really good point. And the ability to look at the whole picture, I think, was in some of those earlier phase dashboards that we had that was like really big picture, what's happening at hospitals across all. And then I think what we heard from colleagues and including members of the advisory council is trying to at some point get to a point where we can compare complexity, though I totally hear you, the risk adjustment and thinking about, some of those really complex services, we're going to miss that.
But it's limited. I mean, the number of services is limited, and also the hospitals that provide those services is limited.
Absolutely.
So we might be able to figure that out.
And I think that's one of the reasons why we kind of try to focus, like, let's do easy visits among peer group B, because that seems like something that's more common and across our state and across the facilities there. But I totally hear you in trying to think of how can we leverage both the early phase dashboards for the big picture, and then when we have questions about variation, thinking about the whole picture, knowing that there's really complex financing happening, how can we maybe take some deep dives without, making blanket statements?
I think that's a good one. Thank you.
The one thing I'd add there is just, I think we'll be really explicit when we present these. It's a good reminder to us to the public hearing, for example, where we're talking to a broader audience, that this is really different from Compare Maine, for example, which does use sort of a logic to go through and think about what are the universe of related codes for an actual visit and sort of more that consumer experience. This is not meant to be that. This is meant to be a little bit more of a rich data source for more, I would say, kind of, sophisticated data users to be able to, again, look longitudinally at how costs have changed, which is something that isn't easy to do in Compare Maine, and kind of have a one-stop shop. So they're really different purposes, and I think that's a really important distinction.
I appreciate that. A request is when you do the outpatient services that are not hospital-based, please make sure that you include the intermeds and the Martin's Points of the world, as well as those providers that, including payer mix for those providers, as well as those that are employed by hospitals.
Yes, absolutely.
Thank you.
Jordan, another question?
Yes.
Oh, thank you. Kaylee Jordan, did you have your hand up?
I did not have my hand up because my raise hand feature is not working, unfortunately, but I put it in the chat, and someone may have actually answered this during your discussion, but I was just wondering if the dashboard is limited in any way to like specific services or CPT codes that are maybe common across all hospitals, or if there are some codes that may apply to certain hospitals and not others.
Yes, thank you for bringing that up. So part of the way that these dashboards were created is across, and I can get you the exact wording for this. I have the methodology, like the 100-page methodology next to me. But in general terms, any CPT code that accounted for less than 2% of spending at a facility was dropped. And so just because it would have been enormous to report on every single service. And we were really interested on services that had decent utilization across a good amount of hospitals for comparison purposes. So there are a good amount of CPT codes or DRG codes or any of those code levels that were dropped because they accounted for less than 2% of total spending at any given facility. Additionally, data is suppressed if there are less than 10 services provided in any given year, any given hospital. So if you were to come in here and let's do, for example, an inpatient pregnancy. Let's do a C-section. You'll see very quickly it has now dropped to 3 hospitals that are providing these services and suppressed, I would say here, when there's less than 10. And there's a couple other suppression techniques. Again, I'm happy to share the methodology with all of you here on why these data become suppressed. But very quickly, you will see in the Trends by Services tab that hospitals that do not, or facilities that do not provide these services will drop off, and you can get to a blank screen pretty quickly. So happy to take guidance too and any feedback you have there. But that is, in general terms, kind of the exclusion of CPT codes or suppression of data that is available in the dashboard.
Got it. Thank you, Katie. That's really helpful. I think one thing I'd flag, and I think it's really good to have this outlined in like the more granular trends by services. But that is like an important distinction when comparing like hospital to hospital, just because like the same services may not be, available or presented in this dashboard in one hospital, but maybe at another. But one thing you could consider doing, which would be, I think, really interesting and informative, is if there's like a common like intersection of services across all hospitals, like they appear for every single hospital and every single year, to see how those change over time in the total payments only, or the total, utilization, just because it makes it a little more apples to apples, versus, when services might vary either by year or across hospitals, depending on, what percentage of total payments it is, or if 10 services were offered in that given year.
Yeah, I think that's a really great point, and something we can definitely dive into is trying to get a subset of services, and something we talked about kind of in the initial stages of the creation of these dashboards is trying to focus on that subset. But the MHO team was so good and could provide us with all the codes. So then, I think we had to pare back from there. So hear you and look forward to maybe creating a more user-friendly set of codes that are across as many facilities as applicable in the state.
Sufficient volume to have,
Yeah.
to address that outlier issue.
And just to clarify, I think this probably came across, but to be sure, once again, double checking with the authority over here, there's suppression in these more detailed dashboards, but that data wouldn't necessarily be suppressed from the sort of aggregate reporting at the outpatient level. So if you're looking at that higher level, you're still looking at kind of the whole universe. It's just when we get down to this display that is so much more specific that those get kind of dropped out of the visualization.
That is correct. Yes, this is a privacy bit when it comes to the visualization for this suppression here.
I was just going to say another nice thing that Katie and I talked Katie Seneschal and I talked about in developing these. I know there's been other analyses where we don't always have utilization and it can be harder to think about price. The nice feature of this is if you're looking at a per unit price, you can really quickly look at utilization and say, is there a wide variation there, or is there, are they roughly in the same kind of categorization, just to get a sense how much of a factor potentially exceptionally low utilization might be and what the price for a given service is at a given location. Are there any other questions? I can't see chat, so I just want to double check.
Not in the chat. I can stop sharing.
It was nice to have it up in case we needed to click
Yes.
through anything else. Great. Well, I know it had only been a week, but we did want to get them out so folks would at least have an opportunity to look before this conversation. As I said, we're hoping to present these at the public hearing at the end of the month. So I think maybe if folks who want to spend more time could take a look, and maybe by the end of next week, let us know if there's feedback. That would be great, and would definitely appreciate, Katie, if there's a little bit more detail that you could share back with the team. I think we'd be happy to take a look at, if they're flagging specific codes. That's something we've tried to chat through and talk through with, other experts and things, but always appreciate more info on that because it's hard from the outside to know when that is occurring and sort of how much confidence we can have in comparability between a given code. Oh, Lisa? Oh, yeah, we haven't usually done feedback from non-advisory council members. I think why don't we can take your question or comment, Lisa. I'm happy to hear from you now. Just a sec, we'll just get you off of, we sort of had folks non-advisory council in like a listening mode, but I think you should be able to come off of mute now.
There, great, thank you so much. I forgot I wasn't supposed to talk, so here I am.
Sorry.
So I was just thinking, for the public hearing and kind of putting this data out to the public and kind of balancing that with the stark reality of how fragile our healthcare infrastructure is right now and how the system isn't working well. So, and I'll use inland as an example. If we had a forum in which we talked about inland utilization, all the money paid to inland, the price per unit, the public has no kind of ability to say, here's a list of fact patterns that led to a hospital closure and they've lost access. So I learned access and sustainability are as important to the public as price. And I'm curious how we balance that out in our public information about healthcare and healthcare services.
It's a big question that I will start to answer now, though I think it may be, beyond the scope of kind of talking about the dashboards alone. I would say that I think affordability is an access issue and is a sustainability issue. I think that the challenges that people might have with deferred care, for example, and ending up in emergency rooms instead of, utilizing a primary care provider because they have such a high, deductible plan, or they're worried about costs, or they're uninsured because premiums have grown so much. I don't know that it's as easy to put, access and affordability into separate categories. I do think that they're interrelated. And I also think that the issue of understanding trade-offs is really important. I think one thing missing is there's not a great way for people to understand the relationship between what they are paying for healthcare and what they're receiving, and sort of where exactly is that money going and how are decisions being made about where it's invested. So I think that that is an issue that certainly these dashboards do not answer alone, but where we are trying continually with the data that we have, which is limited and, subject to just the realities that impact the whole country in terms of data and kind of monitoring spending and the fragmentation of healthcare, to be able to shed some light on that and sort of help people understand relationships between payments and care and variation. I don't disagree with you. Obviously, access is really important, but, and I know this is where we're moving next. I also think that we are on a trajectory where affordability of health insurance coverage, the impact that federal changes and increasing rates are going to have on our insurance markets in the state could become extremely destabilizing. And I think that benefits no one and is not going to help with kind of increased access or sustainability for health systems either. So it's a challenge. I don't think there are easy answers here or simple answers, but I don't know that we can say we need to set affordability aside and focus on access and sustainability, because I don't think we can get there unless we're also addressing prices for consumers. Trevor, it looks like you maybe wanted to add something there.
Yeah, I just want to know too, I think we have to be careful about equating sustainability and price or like compensation to hospitals, because there are other things that impact sustainability. And we see examples at hospital systems around the country that have focused on efficiency measures that have been able to get at least close, if not to profitability on Medicare rates. So I don't think that price can be the only lever that we pull to ensure sustainability within the healthcare delivery system.
And yeah, I think price is one element, but there are drivers of cost that the public is blind to. For example, the nursing home patients living in hospitals, because we have another part of the system that is kind of lost its infrastructure in many ways. So it's not as black and white as a dashboard would portray to the public, and the public saying, here's all this money, here's how much it costs. And why are the OB units closing? Why did a hospital close? Why did all these nursing homes close? I don't have access. There's not a line of sight to match all of that up in the data set.
Yeah, I think that's a good point. I mean, that's exactly the question, the key question that I think from the purchaser perspective that we really want to answer. How is it that prices continue to go up steadily year after year after year, while hospitals and health systems and providers are cutting access simultaneously and paring back? There's this disconnect that I think nobody has a really good answer for at this point.
Yeah, and I would just add, I don't think I would hope nothing about the way that I've described or discussed these dashboards has implied that I'm saying that they are a black and white answer or, are going to be able to answer all the questions or tell the entire story of our health system by any means. On the other hand, I do think greater transparency and greater visibility into the data that we do have, allows people to formulate questions, allows them to base those questions on the reality of what we see in spending data. So I think that it still can move us in the right direction or prompt questions. And maybe that's more what we're always trying to do, as opposed to saying, that we're going to present these and say that there's some, simple answer or some simple blame for healthcare costs. But I think, it's frankly the charge of our office too, to provide this kind of data and to try to make it as digestible for broad audiences, but policymakers in particular. And I do think that we work hard to caveat things, to be clear about limitations of data and to set context around them that allows people to digest them without, walking away with takeaways that can't fairly be drawn from the data.
I think recognizing that this office is still fairly new and you've done a lot of work on hospital data. And you heard me say for a one-note sort of one-note message for a long time at the beginning, which I've backed off of, but I'm going to remind us now, which is it's not just about the provider side. We have a multi-layered financing system, and this whole conversation really suggests the importance of making sure that on your timeline, looking at the administrative costs and complexities, or the complexities and the costs associated with the complexities of the system that we have, which is based on third parties that are traded on Wall Street and for whom there are shareholders that are not our patients who are the end, sort of the end game for those entities feels very important to me. You can't just look at one portion of the healthcare system, which is the provider side, and assume that that's where all the costs are without looking at the whole picture. And that is another big piece of the picture.
It's a good kind of transition actually into maybe the next part of the presentation. Although I will briefly say, I think we have also always tried to ground each conversation in our data analysis in that kind of overview of existing data analysis and planned data analysis. So for example, prescription drug costs we know are an important part of healthcare costs. The MHDO is already producing dashboards that really do everything that I can think of in terms of visibility into that. So we're trying to think, where are places where there isn't visibility? And I would say, similarly, in terms of where the state can reach, if we're talking about insurance costs, that the Bureau and CERF filings provide a lot of data around that. So I'm going to.
Not necessarily on the cost of administration, the prior authorizations, the number of, if you get into that complexity, I would just say that's a place I would encourage this office to perhaps work with the Bureau on.
Yeah. Just a moment. Look at that, I'm on the right tab already. So the reason I said, good moment to transition is I did want to talk a little bit about rate filings. I know folks have probably followed and seen news stories about filing for insurance rates in the individual and small group markets going into 2026. And these filings are quite high relative to what we've seen in recent years. The numbers that you see here are initial and revised, but not final rates. It's my understanding carriers are still working with the Bureau on rate filing. So just to be totally clear, these could change and often do change before rates are finalized. But just to give a general sense here, just in the interest of space, I kind of included the 3 carriers that represent the vast majority of covered lives in both markets. But in revised filings, see a range of 21 up to 30% in the individual market, and then 15 plus percent up to 25% in the small group market. And so, to your point, Katie, seeing these come out, I've spent a fair bit of time in the CERF filings, kind of looking at all the data that carriers submit to the Bureau of Insurance to support these rate filings, and listened to a forum a couple weeks ago. I know that you were on as well, where individuals provided feedback on this. There's definitely major federal impacts happening. I think folks know, and we've talked about before, the end of the enhanced premium tax credits, which were extra tax credits on top of existing advanced premium tax credits for marketplace consumers that most carriers are projecting are going to contract the market and increase morbidity in the market. Generally when health insurance becomes more expensive, the people who are more likely to drop their insurance are the ones who are healthier and not using it. So definitely saw morbidity projections in the market higher than we typically do. And it really important to note, I know, again, this audience probably knows this, but I will just say it out loud, that the removal of those tax credits will have the extra effect of sort of not shielding consumers from these increases. So I think
117% on average.
Yeah. Really significant. And I think we're all, bracing, and I know other states are as well, for what this could mean and how it will change enrollment in markets, and how that, then creates dynamics that can make those markets even less affordable and more challenging. So feels like a moment when, clearly there's interest from the legislature in affordability, but I feel increased sort of awareness that I think that they will be looking to us and looking to others to say, what are we going to do about this? How do we, change this trajectory or step in? And reviewing the rates, in addition to those federal changes, which are significant, it does continue to be the case, which we've seen in prior years, that the biggest driving factors of these increases are the trend in claims payments. It looks like this year there's sort of a balance between increased unit costs and utilization, both for medical services and prescription drugs. I think across the board, I've certainly heard that United and some of the other very large insurers are seeing higher than expected utilization. So thinking about your comments about prior authorization, Katie, there's this challenge, right, where there's all these efforts to try to control utilization and influence there, many of which are create friction with providers and with patients. And meanwhile, utilization continues to grow, and so do per unit prices. So I think across the carriers, as of the latest sort of filings that I had looked at, all of them were projecting that is the biggest contributor to the premium increases that they're requesting. And it looks like all of them are projecting pretty high medical loss ratios, approaching, I think, 87 to 89%, so getting up close to 90%, with 80% being the minimum that they're required to achieve in the individual and small group market, meaning that 80% of the premiums that they're collecting need to be paid out in claims payments, with a small asterisk around allowable quality of care improvements in there as well. And most are projecting, considerably higher than that. And I took a look. I'm certainly not the expert in this. The Bureau examiners and actuaries are, but kind of across administrative expenses, looking to see if there were big increases there across some of the other kind of controllable factors. And the honest answer is I don't know what more can sort of be controlled or how the trajectory of insurance costs can be changed at the state level without addressing the underlying cost issues. And so, we've been thinking more about that and wanted to revisit back when we had talked through policy priority areas back in the fall of kind of 2024 and into, I think maybe the very beginning part of the winter. Collectively, we'd sort of walk through some different domains of policy, and one of them was regulating commercial prices for health services. And I think that's really been brought back to the forefront for me as I think about how to respond to these rate increases and what levers the state might possibly have to do something about them. So I wanted to spend a little time today going through some deeper dive kind of research that we did into what other states are doing in this area, sharing a little bit of that. And then talking a little bit about how we might think about, what policy options are possible or worth considering in this domain in the state of Maine. So when we were looking kind of cost containment policies, or maybe we should say price containment policies, because this is narrow, I understand there's kind of a wider world of cost containment out there, but in terms of direct kind of regulation or intervention to constrain provider prices, most recent state action fell into kind of three categories. There's cost growth target programs, reference-based pricing in state employee health plans, and then reference-based pricing in public option plans. And then there's a couple newer state laws that have passed that fall outside of those. But those are kind of the three big buckets. And I thought I'd just walk through each of those and share a little bit about what's happening in other states and some kind of reflections on challenges and results. Just briefly before I do that, I do think it's worth kind of noting that it definitely feels like this is a place where there's increasing momentum across states, with Massachusetts really leading the charge, but especially from 2017 on, more action. And I think to some extent, the creation of this office was a little bit of a response from the legislature to programs in other states that were starting to look more closely at total cost of care and benchmarking. So the first category, which is definitely the one with by far the most states in it, is these cost growth caps and benchmarking. Both terms are kind of used interchangeably. These establish sort of a shared understanding of how much per capita costs in a state should grow for healthcare. Typically, they use a formula that's tied to some kind of economic metric. So, or a combination of them, thinking about inflation, thinking about growth in household income in a given state, or in some cases, gross state product. But trying to think about sort of tagging and moderating growth to other measures to keep it more in line with what economic growth and the economic experience of families is. In these models, entities kind of across healthcare delivery are held accountable for cost growth. Most of the states do kind of a multi-level measurement, starting at the state level, going down to market level, and then looking specifically at both payers and providers and kind of assessing how they are meeting the target or the benchmark. There's no sort of single formula for this. There's nuance and differences in each of the states around exactly how they establish the targets. And what, percentage of whatever given benchmark or metric they tie to and how they track and enforce them. As I said, Massachusetts was really the leader here and did this much earlier than most other states back in 2013. But there's now 9 states doing this. They really break out into 2 categories, with roughly half of them having some kind of enforcement behind them. So being able to require a performance improvement plan, or in some cases, levying fines for failure to meet the benchmarks. And then the other half really are more kind of about transparency reporting. Some of them can do things like call an entity into a public hearing and have them present, but don't have sort of a firm hand to require compliance. I think it's fair to say that sort of the evidence of the effectiveness of these programs is a little bit mixed. I think generally there's a lot of support and understanding that they've helped states to kind of talk through and think about what is a reasonable level of cost growth, and how can that be measured, and sort of working through some of those important questions. But they're really administratively complex. And so it can be difficult to actually accurately measure and understand how entities are meeting the targets, and again, variation in how much enforcement there is. So while I think there's, some folks would say these have helped to moderate growth, and as always, it's really hard to measure success against like an unknown alternative scenario. These haven't completely changed. It's not as though we see a clear trend or noticeable difference in terms of cost growth or prices in these states when compared to a control group of other states. I will say, though, a benefit I think of this approach is its breadth. To your point, Katie, it does kind of look across the whole continuum and think about how different actors are contributing to overall cost growth. So it's a little bit more holistic in that sense, I think, than others that we might discuss, but the trade-off there is just the complexity. So we did list out in these slides, which I will share after this meeting. I apologize that I failed to do that in advance for this one, but we'll share them out. But I'm not going to walk through each and every one. This shares a little bit more information about the specifics for each of the states that have established one of these programs. But I think that that's the general gist for you for this point. Feel free, as always, to raise a hand or interrupt me if you have any questions as I move along. So the next area is reference-based pricing in public employee health plans. In these programs, hospital payments in most cases are capped at a certain level, typically a percentage of Medicare rates, just for public employee plans, whether that's state employees or in some cases school employees. The range of them varies a little bit. Montana was really the first state to do this and got a lot of attention several years ago for implementing this program, but more recently, Oregon and Washington have done so legislatively. I understand from some survey results that the Georgetown Center for Health Reform put out that there's some other states, they didn't share specifically which ones, that use some form of reference-based pricing. They did some interviews, and it sounds like both Oklahoma and South Carolina actually use essentially a fee schedule type of structure and more of a take it or leave it approach, but there's not as much detail about those. So I kind of stuck to the plans that have followed in Montana's steps and looked at Medicare prices. So in Oregon, their cap was 200% of Medicare prices in network and 185% out of network. That program's been in effect for a couple of years now. So just recently, there was actually a pretty comprehensive evaluation published by Roz Murray at Brown University that estimated about $107 million in savings to the state employee health plan during the period of operation, and did take a look at whether there was any evidence of reductions in network access, providers leaving that plan's network, or of cost sharing to shifting, to other payers. So increased negotiated rates with other commercial health insurance carriers in the state, and did not find any evidence of that. I think they found a little bit of an uptick in utilization that they thought may be in response to the policy, but I don't think it was conclusive yet, but was sort of a question for future research to understand. The Washington state employee the Washington Healthcare Authority, which administers these plans, also just had legislation passed only in this past session this year in 2025 that would similarly establish a 200% cap relative to Medicare rates for hospitals. And their policy is really interesting in that it also sets minimum payment levels. So they took a look, and this is what Rudy was referencing earlier as well, and actually said, we're going to cap sort of outlier high prices on one end, but then we want to bring up our reimbursement for both primary care and behavioral health care and invest more of our resources into that. So that program hasn't been implemented yet. It is supposed to go into effect in 2027. For reference-based pricing in public option plans, I think we've talked more about this in the past, or I may just be remembering the time I spent discussing it in our public option report to the legislature. But just as a reminder, there's really two examples of this across the country with slightly different flavors. So the state of Washington implemented a public option plan, and for that established a cap of 160% of Medicare rates for hospitals, but with some exemptions for rurals, and in fact, actually a floor of 101% of Medicare for rural critical access hospitals. And they also established a floor for primary care, so sort of similar to that Washington model where they said we want to bring down rates on one end, but bring them up for certain services that we feel like we could be investing more in. So community hospitals, in addition to CAUSE, had that 101% Medicare floor. So this really looked directly at provider rates and capped them, and relied on the plans that were brought in both these cases. It's commercial insurers that are administering these plans, and look to them to kind of administer and ensure savings. I will say, well, why don't I talk about Colorado, and then I can talk results a little bit. So Colorado used a different model where they similarly went to their commercial plans and required that commercial plans participating in their individual market offer these public option plans. And they set targets for them of reductions in premiums, and essentially said, if you're unable to achieve those reductions in premiums, report back to us, tell us why that is, and sort of gave a margin rate essentially for their Department of Insurance to cap hospital prices or provider prices in cases where the targets weren't met. I think in terms of the implementation of these programs, I think both kind of got off to a slower start than hoped. Initially, Washington struggled with provider participation in their network that really limited the availability of the public option plans geographically in the state. Their legislature came back in and required participation in at least one of the public option plans for most hospitals in the state. So they were gradually able to expand that plan. Those plans are available statewide now. And from what I understand, they're now the lowest silver metal plan available in the marketplace in all of the counties in Washington, and they've grown enrollment up to 30%. So it's not been transformative, I think, for healthcare costs in the state, but it is showing some success of pulling down premiums relative to where they would otherwise be, and creating a little bit more competition. The growth in those plans in terms of premium costs have also been lower than the non-public option plans in the state. In Colorado, similarly, I think they set some really aggressive premium reduction targets that they found difficult to meet. I think their target for 2025 was to reduce premiums by 15%, which, given the overall, headwinds and kind of trajectory of costs, is very challenging. They've also seen, they sort of saw earlier, more significant enrollment than Washington, and there's some evidence that they have also slowed growth. There was a study that took a look at what the growth in premium costs in Colorado when compared to a group of comparison states, and did find that premium growth there was a little bit lower, but I think not quite meeting the expectations that were set when that policy was passed. In thinking about public option plans, and I know, again, I've talked about this at length in the public option report for a couple of years ago, but there's definitely advantages, I think, to public option plans, one being kind of the opportunity to test something in a relatively narrow segment of the market, and to focus on consumers that may be the most cost sensitive and who have been kind of exposed the most to premium increases in recent years, or high premiums in some of these states in some examples. And historically, there's generally been some ability to kind of supercharge funding for these by applying for waivers from the federal government. If a state's successfully able to lower premiums through something like a cap on provider prices, they've been able to kind of capture the savings and reduce advanced premium tax credit expenses for the federal government and invest that in priorities like lowering kind of barriers to care, providing wraparound subsidies. I think in Colorado's case, they were able to provide some subsidization to consumers who were otherwise ineligible in their market and relatively healthy. That is probably more challenging in today's environment, just to be realistic. And there's definitely challenges to working with a public option plan. There is so much complexity involved in introducing a new option in the marketplace. In terms of just market dynamics, factors like what happens with adverse selection in a plan if you're offering a plan that's lower cost and more, or especially if it's a similar cost but more generous, you can often end up with an enrollee population that's sicker that makes it difficult to maintain, or there can be unintended consequences for pass-through of APTCs if you're not thinking about kind of strategy around where you're lowering premiums. So it does introduce a lot of additional layers and considerations, I think, to try to think about a model that uses these reference-based prices as an option to generate savings, but limits it to a selection of plans in a market that's already tends to be volatile and will probably be volatile in the future. I think that's what we've kind of seen with those two programs, where it's been more complex to implement than they had expected or hoped. So then finally, just an update on some new developments in other states more recently. Starting with Indiana, just this session, Indiana passed a law mandating that nonprofit hospitals only in their state limit their aggregate average inpatient and outpatient hospital prices to the statewide average with a target of June 2029. My understanding is they've sort of made this potentially conditional or made nonprofit status conditional on meeting those benchmarks. It's an unusual approach. I think there's sometimes at an academic level been discussion about using average current commercial prices as a benchmark. I'm not totally clear. I tried as I was putting these together to see if I could find how they are thinking about this, whether it is a one-time sort of readjustment in price or if it will continue after the first year, because obviously once you bring down prices to the prior average, your average is going to drop again. So I'm not 100% sure on that, just to be transparent, because this is still pretty new. My understanding of where it stands is they have an Office of Management and Budget that was tasked in the law with determining what this aggregate average price was going to be and then moving forward with implementation, but it's just a really different model there, and one that was, from my perspective, at least a little more under the radar and didn't hear much as much about as it was being considered. In Delaware, this sort of falls into the category that we talked about before of cost growth targets, but it has a little bit of a different flavor. They have had a cost growth target since 2018, 2019, but did not have any enforcement. And just this year, the legislature kind of tasked this new Diamond State Hospital Cost Review Board with overseeing hospital compliance with the benchmark. They're going to go through a process of data collection and transparency to understand whether hospitals are meeting the benchmark. And then if they are not and they can't agree to a PIP with the board, the sort of final step is the board has authority to kind of march in and review future budgets. And I should say here, approved. So that it's not just a review and feedback. It is, they can actually sort of overturn a decision about a budget. This law had a lawsuit filed against it by ChristianaCare, I think, one of the systems there. Some of the claims were dismissed. There was some, I can't think of the word, concerns about the transparency and some arguments about that I understand were dismissed, and that piece about kind of reviewing compliance with the benchmark isn't going to be considered, but the component of reviewing and sort of overruling a board decision on the budget is being challenged and was allowed to move forward with an argument around sort of the constitutional rights of the business or organization to have their board make decisions. So that is something that's still pending, just as a flag. And then finally, there's a little bit of a connection there, I should have said. That model, I think, builds a little bit on the Green Mountain Care Board in Vermont, which has existed for quite a while. I think they were established back when the state of Vermont was thinking about single payer healthcare and kind of exploring options there. And that board has had authority to review budgets for hospitals and I believe provide feedback and recommendations. Off the top of my head, I don't think that they do have the authority to completely overrule, but they, oh, they do. Okay. Thank you for the reminder. And they were just tasked by the legislature in the state of Vermont with actually setting Medicare-based price caps for hospitals on a very aggressive timeline for 2027, alongside establishing global hospital budgets by 2030. So 2 different models and structures for thinking about financing of hospitals. My understanding is that really came out of concern in the state around the single insurer that is very dominant in their market having solvency issues and worries about destabilization of their health insurance market and wanting to sort of take more decisive firm action. But that one also seemed to have come together pretty quickly. It wasn't something that was on our radar at all last fall, but wanted to flag that one, and a little bit unique in that it focuses on hospital prices, I think, initially, but does also have some authority to cap prices outside of hospitals for other types of providers. That was a lot of ground, I know. And I think we're still, thinking through and trying to absorb and brainstorm a little around how policies like this would impact Maine and what they would mean, and whether there is potential of a pathway forward for kind of a policy in this realm. And so wanted to pause. I know I'm sure there will be feedback on this, but a few things that we're obviously, thinking through and that are really key questions to answer. The first is reach of policy. There's, a pretty wide range of kind of how applicable these policies are, everything from kind of across the entire, all markets or across the commercial market down to, again, like just one segment of plans only on a marketplace or just a state employee plan. And so there's a tension there, or a trade-off in terms of thinking how broadly could you have maybe a positive impact in terms of cost, but also the broader the impact, the more disruptive it is and the more the impact on providers. So feeding into those 2 questions, thinking about affordability, how much could varying structures impact household or employer healthcare costs in terms of, what would different levels of either caps or floors and their combination kind of look like, and what would that realize in terms of savings? How cost savings potentially from a model like this could be assured for consumers. I think a big question, especially if you're thinking more broadly than an individual plan administered by the state, is, how would you make sure that actual people and businesses kind of yielded any savings from this or benefited from them, rather than them being kind of eaten up or disappearing in that long chain of healthcare delivery, particularly by health insurers. And finally, and very importantly, and I'm sure there will be folks with thoughts on this, provider impact. Clearly, as we know, there are hospitals that are struggling, that are on tight margins or negative margins, trying to understand what the impact would be of rate caps, but also of floors. Again, this isn't necessarily thinking of reductions in total spending, but potentially shifts of spending between different types of services that might better support care delivery. Kind of what would those look like on a statewide level, on an individual system or hospital or provider level, and what would that mean for overall financial stability and margins? So it's a lot of big questions to answer. I will say again, though, I think that this is an area where, given the trajectory of premiums and the limited options available to state policymakers, I think it's a question that's going to come up. And an area that I want to further explore and think about outlining solutions in, because I do see it as a place where there is opportunity to make meaningful change, as challenging as it is. I know it's not a simple one. I know it's hard to conceive of and would take a lot of thoughtful design, but I see a lot of promise here as well. I'll pause there. Yeah, Trevor, I see your hand up.
Yeah, thanks, Meg. This is really interesting. Have you found any examples of states that pair provider like price or growth caps with reforms on the carrier side? I'm thinking about Katie's comment about the administrative complexity and burden on the carrier side. Perhaps there's an opportunity to alleviate some of those pressures from the hospital in combination with addressing the price issue.
Yeah, it's an interesting question. I thought I had an answer for you, but it might be a little different. The direction I was going when you first started to ask your question was to mention the state of Rhode Island, where their cost growth targets are embedded in their rate review process. So part of their rate review is sort of putting pressure on carriers to ensure that across the board cost growth targets are met. But if you're thinking more about reforms to ease kind of burden on providers or find ways to pair reforms, I can't off the top of my head, at least not in a single policy, although I believe that Indiana may have done some of that, but just in different policy vehicles kind of in the same year. So I would have to double check on that. There's nothing that comes immediately to mind for me.
Yeah, I would be curious about hearing from Katie and Lisa about, what they see as the primary sort of cost drivers on their side, derived from carrier practices that they would like to see addressed.
Yeah.
And I think we can prepare for the public comment period for data informed analysis on that, but certainly the whole morass related to prior authorizations which incredibly cumbersome, expensive to administer, frustrating for all involved patients and providers alike, and 91% of them ultimately get approved. So it's not that there's this sort of significant savings associated with it. And I'd be curious what I don't know is of the 9% that don't get approved, how many of those just get dropped? Like people don't recognize that they need to appeal them. So it's like a race to the bottom right now as it relates to prior auths. So that's one thing. I just heard another example. As I was coming in, I was listening to a call, and Aetna which I will admit is our TPA, is in the process of implementing a new mid-year contract policy change, which you've heard us complaining about for a long time, that will, in which they will uniformly decide based on acuity, I guess, who needs to be inpatient and who they will pay for observation status. So and they have some methodology around that, but that's going to create a whole nother level of complexity and challenges. It's those kinds of things. We have over 1,000 people who work in our business office at Maine Health. That's a lot of people who are administering claims in some way or another, or administering the system. So, and most of those are not Medicare or Medicaid. They're not straight Medicare, governmental Medicare, or Medicaid. By far the most are either Medicare Advantage and or commercial. So
yeah, I wouldn't want to throw the baby out with the bathwater in terms of prior auth, but I have no doubt that there is lots of opportunity for improvement in how those are handled for both providers and patients. But Katie, has Maine Health actually like costed out the cost of dealing with all those prior auths? You said like 1,000 people, obviously. That's quite
not just prior auth. Yes.
Yeah, exactly. So like if say prior auth disappeared tomorrow, how many of those 1,000 people would you keep on staff versus?
Yeah, and I can't answer that question right now, but I think we can put together some data as it relates to what it would look like to have a more efficient system. Quite frankly, we could look at Medicare and Medicaid, which are far more efficient in the way that they're administered. I'm not going to say they're efficient in the amounts that they pay us, but that's a place we could look at sort of the human capital that goes into administering those versus the private plans.
I would say I'd be really interested too in better understanding what feel like reasonable limitations that would have a significant impact, and maybe particularly with a focus on what's possible in terms of policy. No, I've been trying to read a little bit about some of the federal action around sort of like API systems, and so understand some of it might be more operational and how information is exchanged and approved. But I also think for me on the outside trying to understand this issue better, like understanding, is there a carrier that's actually like doing it reasonably well? Are there sets of services where you feel like, listen, we understand prior authorization here, but we really don't understand it here? You know, I think I would love to better understand what feels like, to, you know, to Trevor's point, understanding that probably eliminating prior auth isn't reasonable, but
No,
are there?
We would even want to do that. I think as the largest private employer in the state, we wouldn't want to eliminate it either. But yes, there are like swaths of services that we would say are for which prior auth is absolutely meaningless. Meaningless from a cost savings perspective and meaningful in terms of adding to the cost and the cost burden.
Yeah, I think if you're willing to, you know, include some of that in your comments, or if you want to do it more informally and share information, I would love to learn more about that. Lisa, did you want to respond to Trevor's question too?
Yes, I do. So it's interesting when you think about the prior auth denial challenge for hospitals and the geographic spread of where our hospitals are. Because for some of our markets, the challenge really is Medicare Advantage, for which we have limited ability. So if you think about A.R. Gould and Presque Isle, for example, their payer mix, I think, is 72% governmental payers. And they have a high density of Medicare Advantage, like Maine does generally. So the ability of a proposal like this to really have impact in some of our rural areas would be limited. So I just wanted to raise that point, that there will be a geographic disparity in, if we took this approach, in how some hospitals are able to significantly change their cost structure around managing that prior auth and denial process versus others.
Yeah, point well taken. And I know I've had to raise that in various contexts and various times with the legislature, that sometimes ideas like this, it's one thing to estimate total savings if you could completely, you know, eliminate or change the structure, but there are markets that we don't have reach into. So we kind of have to think about scale, and appreciate you calling out that that wouldn't be evenly distributed, that there would be some variation in terms of impact based on geography.
So one question I have related to the provider impact that you mentioned here is just, I think it's reimbursement and margins. It would be helpful to look at the states that have enacted some of these things to determine, were there layoffs as a result? Because I can tell you in Vermont, there were layoffs, significant layoffs and service closures as a result of the Green Mountain Care Board's most recent action. Like they closed psychiatric services at a rural hospital that had been losing money because of that. So understanding the implications of some of these at the service, at the access level, seems really important, to Lisa's points earlier, as it relates to how these prices and cost mechanisms translate into the availability of care.
Absolutely. And I think it ties into the question around floors. You know, clearly the couple of states that have moved in that direction have focused on primary care and behavioral health care, but the question of degrees of magnitude and how meaningful more investment in some areas could be in terms of, we've talked about cost shifting between different service categories. Obviously, it looks different if there's some movement of funding from one area into another versus, a cap. And I'd be curious if there's other services that folks would put on the table and say, if we were thinking about areas where we really wish we could come up, either closer to Medicare or to a multiple of Medicare, are there other areas that come to mind where you really feel like commercial payment rates are kind of running behind the public payers? I know we talked about the scope, like care management, where there's just gaps in actual coverage, but in terms of,
I think behavioral health.
that's what we've kind of seen looking at other states. It does seem like those are the places where they've seen in data. I think that was what drove Washington's decision in particular.
Yeah.
Other questions or feedback? I know this is, as I said, it's a big set of questions. It's a lot to think through, but I wanted to set up this conversation because I have been thinking so much more about it over the last several weeks, and kind of set up and would like to come back to this group at another meeting this fall and maybe talk through options. Again, devil is in the details, I understand, but would welcome, especially if there are pieces that we're missing in terms of thinking about how we could assess or begin to model out impact and think about developing some options. If there's anything that's not on this list that really should be, welcome that feedback.
It's a lot to digest.
Yeah, I understand. As always.
Can I just note, Meg,
Yeah.
we're hosting a presentation. I believe it's on the 23rd of this month with Michael Bailett, who's worked on a lot of these state initiatives, and he's going to be doing a sort of a deep dive on different state approaches to price and growth caps. If anybody's interested in attending that, feel free to shoot me an email and we can get you signed up. It's going to be in Falmouth.
Oh, perfect. Thanks, Trevor. Appreciate that. Great. I was just going to say too, you all know where to reach me. So as you digest a little bit more, if you'd like to talk more, have more thoughts to share, please just let me know. I think we came closer to using our full 2 hours, which doesn't surprise me. I know we were covering a lot of ground. So I think we can start to wrap up there just with a reminder. And I think maybe Keely, if you wouldn't mind sending around just so people have it by the end of next week. We'd love any written feedback that you have on the dashboards, just so we can do any final refining as we prep. And then the public hearing on the 29th. So hope to see many of you there. And if there are ways you can, would suggest we sort of share the information about that, welcome feedback and welcome your help having as broad a participation as possible. Certainly a lot of interest from consumers in these issues, as we saw those of us who joined the forum that the Bureau hosted. Oh, perfect. I just saw Trevor in the chat said the 24th from 8 to 10 in Falmouth. And to shoot an email if you're interested in attending. We can maybe pop that in the email to everybody too, just so they have that in writing too, Trevor. Okay, great. Well, thank you all. As always, nice to see and hear from you. Appreciate the time and the feedback. And yeah, we'll see you later this month and then again a little bit later in the fall for another meeting. But I hope you all have a great back to school season for those who have parents or kids who are heading back, and otherwise just a great start to the fall. Thanks. Supposed to be in charge, sorry.